Okay. So we start. Are we all comfortable? On that note?
Yes, thank you.
All right, so good morning all participants and our speakers. I want to welcome you all to this platform wherein we can hear from 3 vibrant midwifery educators who will lead us or give us insights into certain things that we might be lacking or reinforce what we have been doing. So participants, you are welcome, but there is one rule: please be muted so that we listen to whatever we are hearing from our 3 presenters, so that to cut off background noises. And to our presenters, you are welcome. Thank you for spending time to put your slides together, and we are ready to be challenged by your presentations. So, with not much ado, I'd like to call on Dr. Sarah. Dr. Sarah, please put on your screen, your video, and we are waiting your presentation. Thank you. Dr. Sarah?
Is it Sarah? Let me start it? Oh, okay.
Yes, please. Your video can start now, 15 minutes. We are all ready and set for you.
Okay, so good afternoon, good morning, good evening, if there's anybody in the evening, any people in the evening. So I'm going to present on developing a midwifery leadership pipeline for Zambia. And I just have 3 slides. In fact, it's 2 slides because the other one is just for introduction. So I'll talk about the actual leadership pipeline. I'll talk about defining leadership development and the current situation for midwifery leadership and the prioritizing the leadership agenda for Zambia. I also talk about strengthening the midwifery leadership structure across the provinces. So what do I mean when I talk about leadership pipeline? So leadership pipeline is a situation where you have a pool of leaders that are in waiting for succession in case the other leaders that are in those positions leave or retire or die. There should be some pool of leaders that a country is able to bank on. And then when we talk about leadership development, this simply means where you're going to mentor the leaders to be, where you do the trainings, where you do the training in regard to the position that you want to prepare those leaders for. So that is leadership development, and each country is requested to have such kind of a development plan so that they don't lack in case where a leader is gone or a leader retires. So to talk briefly on the current situation for midwifery leadership in Zambia, I must say we do not have a succession plan, so to say. We have our Director Nursing Services, Nursing and Midwifery Services at the Ministry of Health. She's not a midwife, but we have a Chief Nursing Officer who is working under the Director Nursing Services. She's a midwife. We also have at that level other midwives who are chief nursing officers in different areas. For instance, we have a chief nursing officer in safe motherhood. We also have a chief nursing officer for adolescent health. So we do not have a chief midwifery officer at that level. And this is what I think is lacking for our country, because we really need a chief midwifery officer at that level. And also at provincial level, we need to have leadership that is to do with midwifery. So what can we do as a country in prioritizing the leadership agenda? So as a country, we need to start looking at what I've just said as gaps, where we need to have a chief midwifery officer at the Ministry of Health and have the provincial midwifery officers for every province of Zambia. We have 10 provinces, and for each province, we have a provincial nursing officer. But the provincial nursing officers, we are calling MNCH, and we have another provincial nursing officer who is called the provincial nursing officer standards. But what it is that we do not see the strengths of this provincial nursing officer at that provincial level carrying on the midwifery agenda, so to say, in leadership, where they are leading the midwifery agenda to another level, cascading it to the district, because that's what we need to see. We need to see that stream of leadership, and even the succession should be in those lines. At district level, we need to have leaders that are being prepared to take over the district leadership. At provincial level, we need to have that. So that is the prioritizing that we need to talk about when we talk about leadership agenda, especially in midwifery. As a president for the Midwives Association of Zambia, we've seen these gaps even affecting our association in terms of how we are managing our activities as an association. Because what we expect is to have a structure that is being talked about even at global level. When you look at what the International Confederation of Midwives is advocating for, is to have a chief midwifery officer at that level, so that policies are made, and that chief midwifery officer should be on board as policies are being made. Sorry. So the other thing is, the other point that I'm going to talk to is strengthening of midwifery leadership at provincial levels. I think I've already talked about the need to have those structures at that level. Again, I'll refer to how we are operating as an association and how we are having, gaps in terms of delivering the midwifery, the so-called midwifery agenda at that level. We have a critical shortage of midwives, and as such, even at provincial level, we are always, the provincial nursing officers, the midwifery officers are complaining about, the issue of not having, midwifery in the community. And this is not because we do not have midwives who are qualified. We do have quite a number of midwives who have graduated, but they can't find employment because the structure, the system, the establishment cannot absorb them. So that issue, really, even if we have so many midwives graduating every year, we still have those gaps, because that leadership at that level is not able to advocate for a revision of the establishment. Because for us as an association, that's what we are advocating for. If there can be a revision of the establishment so that we have midwives at every level, including community midwifery, which is an issue that has been pending for quite some years. And the maternal mortality, I think the shortage contributes to the maternal mortality, because some of the cases, some of the deaths which are preventable are coming from the community. At community level, there is nobody to manage that woman who is in labor. They only come to a facility, maybe a facility which is even more than 20 kilometers from where they are, and to come and meet maybe a community health assistant. There is no midwife there. So all those are issues that has to do with poor leadership. that has to do with lack of leadership at that level. So the leadership pipeline is quite, I could say, maybe crooked, something that is not straightforward, that we can say, okay, we have this leadership and midwifery will carry on. The midwifery agenda will carry on. That's the gap that, that we have as a country. So I think I need to, not to take you to data and all that. I just thought maybe I'd just talk briefly on the picture of Zambia. Thank you very much.
Thank you, Dr. Sarah. You finished your presentation?
Yes, I hope people have heard. I'm a fast speaker, but I just hope my presentation was clear. But I can go to the next slide just to quickly talk about the succession plan that I had presented here, just to show a picture of what we really need. I still have minutes. Okay,
yes,
so the succession management plan is important because it prepares management, just like I said, that under any unfortunate circumstances, the organization will be able to fill in the position. And this process, like I said, is for grooming, training, and giving skills and retaining employees. So when you look at on your left, is it on your right? There is a cycle. The first thing that needs to be done is you need to identify key positions. Which are key positions? And for our sake, we are looking at a chief midwifery officer at the Ministry of Health as one of the positions at the provincial level and district levels. So, and then you assess the skills and abilities that they need to have for them to come and carry on that position. After that, you identify the employees. Around the provinces, we do have people who are leaders, who can be able to carry on, who can be able to get the skills and be able to apply the skills that they have acquired. And we need to develop and train employees. These employees, we're still talking about the midwives now. Those that have been identified, train them, give them the leadership skills that they need, give them the knowledge that they need for them to come and carry on that leadership. And then continue evaluating the process. That is the preparation of those leaders. But this, like I said, this doesn't happen even in our country. We do not have, I think there's no time, whether it's time or it's just lack of plans for us to develop these succession plans. Just like it is in the association, I need to work with somebody that is going to take over me because I'm not going to be president forever. I need to groom somebody that is going to take on, come end of my term of office, I need to really groom somebody. So I'm already working with those that I know these can be able to take up leadership. Yeah. So this is the end of my presentation. I hope now the time at least has been used effectively. Thank you so much.
Yes, thank you so much. It is quite precise and to the point. I think we will go on to the next speaker. Or maybe, please, I hope people are jotting down. I see some people are already sending some questions, and we will go to the chat and see how many questions we can answer. I myself has jotted down one or two. But notwithstanding that, we can move on to Professor Edward. Edward.
Yes, good morning, good afternoon, good evening, ladies and gentlemen. I am going to share my screen.
That's my hand.
I hope it is sharing. Yes, I am Professor Edward Kumakech. I'm the Dean, Faculty of Health Sciences at Lira University in Northern Uganda. Today, I am going to share with you a presentation about developing new advanced midwifery practice programs in Northern Uganda. This is really an experience that we are going to share from the deepest of our hearts from Northern Uganda. The outline of my presentation is I'll take you through the location of Lira University in Uganda, and then I'll talk about developing the Bachelor of Midwifery program, opportunities and challenges of Bachelor of Midwifery program, and then developing the Master in Midwifery Science program, successes with international exchanges in midwifery program, challenges with international exchange in midwifery programs, and then a few suggestions on how we can maximize contributions from international exchange. Lira University is located in Africa, in Uganda, and Uganda is part of Eastern Africa. And Lira is in the northern part of Uganda, in a city called Lira City West. Developing the Bachelor of Science in Midwifery program at Lira University, Uganda. Lira University is a new public university in northern Uganda that started the Bachelor of Science in Midwifery program. It's a 4-year program in 2013. And this program has been admitting both students from the college, that is direct advanced certificate of education, diploma nurses and midwives, and mature age candidates. This program is a counterpart to the routine Bachelor of Science in Nursing 4-year program. I wanted to let you know that in Uganda, and I think in many parts of Africa, we have been having midwifery training for 2.5 years, and that is called enrolled midwifery training. And these people are trained basically to conduct normal deliveries. And then we also have 4-year programs for diploma and 4-year programs for degree, where midwifery is a component in addition to other nursing skills. So this innovation from Lira University of having midwifery training for 4 years is really an extended learning period for midwifery courses like normal midwifery, maternal child health, abnormal midwifery, obstetrics and gynecology, in addition to the basic nursing courses like the basic medical sciences, behavioral sciences, public health sciences, medical, surgical, pediatric, and psychiatric nursing. So this program is giving more time for the candidates to learn midwifery and practice it, including things that were thought not to be performed by midwives. This is the Faculty of Health Sciences at Lira University that is housing the Bachelor of Midwifery program. And I would like to note that the design of this structure got a lot of input from international exchange expatriates. On the upper floor is where we have the classrooms, we have the clinical skills laboratory, and we have the offices. And then on the ground floor is where we have the clinics. That is where we have the antenatal clinics, we have maternal child health clinics, we have all the immunization services going on. And then the building on the left is actually maternity unit, where we conduct deliveries, and it also has an obstetric theater plus postnatal ward. So it's a structure in a way that the faculty and the students have easy access to mothers, children to actual practice on just within the building. The Bachelor in Midwifery program at Lira University had a lot of questions that arose. And many of these questions were coming from the regulatory bodies and other stakeholders, including our colleagues, the medical doctors, obstetricians, and gynecologists. And one of the major questions have been, the 4-year training duration is too long, given that there are 2.5-year programs, even 9 months extension program for training midwives. What will the midwives exactly learn in all these 4 years? And then there were questions like, will the degree midwives' knowledge and skills be within the scope of practice for midwives in the country? Are the staffs in the university qualified enough academically to teach degree midwifery students? Which health facilities will the degree midwifery students do their clinical practice rotation from? And then who will supervise them when they are at the clinical practice? What will be the job positions, titles, duties, and responsibilities of degree midwives? So all these questions are arising. And of course, with the collaboration with international exchanges, we were able to put together this very nice program that virtually answers all those questions. And we also have this teaching hospital. This is the Lira University Teaching Hospital, where the students actually do nursing and surgical pediatric skills from. So again, the building is in such a manner that on the right, we have wards. There are inpatients, surgical theaters, and then on the left, actual are classrooms, tutorial rooms, and outpatient departments. So this is just within 10 meters from the Faculty of Health Sciences. It's within the Lira University campus. Again, giving easy access for both students and faculty to access practicum site, to access patients, and practice skills on. Despite the various questions that have been raised on the midwifery program, the program was very attractive. And I can show you a graph showing the graduation rate from since when we started. From 2013, 34 candidates graduated, and then it increased to 41 in 2014. And then in 2015, there were 61. And then we had 76, 74, 61, and currently we have about 69 about to graduate in December this year. So you can see the program is very attractive, despite the questions people were raising about where will they work from, what will they do, who will supervise them. And despite this, it is attracting a lot of interest, and actually we are failing to manage the demand. In 2019, we conducted a tracer study of the graduates from the program. And we found out that the graduates were able to perform 92% of the skills that they obtained from the training. And we published this paper in Annals of Global Health in 2020. And there were only 8% of the skills that they were not able to practice. Those skills that they were not able to practice were delivering babies with shoulder dystocia, performing cephalosiotomy, performing cesarean section, performing laparotomies for ectopic pregnancies, repairing 3rd and 4th degree perineal tears. And the reasons why they were not able to perform these procedures were basically the feeling by their supervisors at the clinical sites that they are not licensed to perform those procedures, despite the learning that they got from the training schools. And also the feeling that they are inadequate to practice the skills. There were also a lot of competition for cases with the medical doctors, obstetricians, and gynecologists, nurses. Everyone is looking for these abnormal cases to practice on. And then, of course, unnecessary referral of the abnormal cases to theater for operation. So I think the candidates are not being given a chance to try the maneuvers. So the diploma nurses who are the in charges of the clinical units would just refer the cases straight to theater. And of course, there was also lack of expertise among the clinical supervisors without the degrees in midwifery. They really didn't know how to supervise these graduates to perform those skills. And then we have embarked on developing Master in Midwifery Science program, which will be 2 years. And there are a lot of justifications to this. One of these justifications is that if we have midwives with master's degree. And then the pregnant mothers and the postnatal mothers and their newborns will benefit a lot from this, because these midwives with masters will go on to supervise the bachelor degree midwives in their clinical practices. And then, of course, a lot of time and cost savings will be there, as these master and degree midwives will be able to perform some of the abnormal midwifery cases and some of the obstetrical surgical maneuvers. And then, of course, maternal perinatal mortalities will reduce, because the degree midwives and even these master midwives will be based in community-based health facilities where they will give the intervention straight away. And then there will be competent supervision of the clinical practice of bachelor degree midwives. So we have embarked on developing this, and where we have reached now, we have received approval to start the program. Despite this approval, there are still many questions people are asking about this master's program. How different will it be with the bachelors? What will the master midwives perform that is different from the degree midwives? Do universities have qualified staff to teach the master degree midwives? Which health facilities will the master degree midwives practice from? Do these facilities have practicums and qualified staff to supervise? So these kind of questions are coming up, and how will they be registered? Despite this, we have a lot of answers. The questions I'm asking: did Lira University succeed in implementing the bachelor degree program? The answer is yes. Are the bachelor degree midwives of good quality? They are actually of excellent quality. Did the bachelor degree midwives get jobs and duties to practice? Yes. Most of them and almost all of them are practicing now. Some of them are for internship, others have gotten jobs. Will Lira University succeed in implementing the master degree program? Definitely yes. And then will it be of good quality? The answer is yes. So what are the success factors? The success lies in international exchange. As of Lira University, we have educators coming from the US, SEED Global Health Educators. And these people come, they bring us a lot of resources. We also have educators from Malawi. We have educators coming from Mass General Hospital in the US. We have educators coming from Pool Africa Link in the UK. We have educators from Minnesota University in the US and Michigan. So these people bring a lot of educators with masters and even PhD degrees. Therefore, questions whether we shall be able or unable to implement the curriculum is answered by these educators. They also bring educators with advanced midwifery practice experience. We get educators with 20 years of practice as master midwife. We have educators with 25, even those with almost 30 years of experience. And then these educators bring international benchmarking of the program content. So they provide us opportunity to compare our content of the curriculum with that in the US or with that in Europe. And this helps us to improve the content, the course outline, the learning outcomes, and also the teaching methodologies. And then they bring a lot of updated resources, textbooks, and e-resources that helps in teaching the program. We got a lot of support from infrastructure, equipment, and instrument. We have a lot of mannequins, including computers, that we are actually using for training the advanced practice midwives. They often conduct faculty training. We have been trained how to use ultrasound, how to use VScan, and currently the faculties are receiving training on ICT skills, how to use Microsoft programs. And then they have also been helping in developing training manuals for faculty. For example, we have an adult teaching and learning manual that has been developed with the support from international exchange, and our faculty are currently using it. They also help in supervision of students' research projects, ICT training and equipment. I've already talked about this. And then we have simulation teaching methodologies. This is exciting. You know, the traditional teaching has been didactic lectures in classroom, and then students are sent to the clinical area. But these international exchange programs have brought us simulators and mannequins that can actually mimic patient conditions. There are simulators that can bleed. There are simulators that can cry. There are simulators that can perform all sorts of conditions. And this gives the students opportunities to learn on a safe environment on mannequins. And by the time they go to the clinical area, they have very good skills. And they help on teaching, and then they follow on partnership and collaboration with expatriates. This is the Midwifery Skills Laboratory we have. It is well equipped. You can see we have all sorts of mannequin. The Mama U, the neonatally, all these equipments are in the skills laboratory, and we are able to partition it into cubicles. And we are even using it to perform all the practice with the midwives before we send them to the clinical area. They become competent practicing midwifery skills from this skills laboratory before sending them to the laboratory. This is one of the Mama Zoe that we have. We have several of these, and the students practice on it from the skills laboratory. We have also an anatomical models, the skeleton, in the skills laboratory that the students practice on. We have up-to-date textbooks that we have acquired with the help of international exchange. In some places, people are still reading Margaret Miles' 4th edition, but for us, we now have 16th edition of Margaret Miles for midwives. This is the reference book that we have managed to acquire with the help of international exchange. What are some of the challenges with international exchange? One of the major challenges has been in the clinical practical sites, which are not well equipped with the advanced practice midwifery compared to the clinical skills and laboratories. In the laboratories, we have all these equipments that we perform, we practice on, but when we go into the health facilities, many of these equipments are missing, and it brings a lot of frustration, both to international exchange expatriates, the faculty, and the students. Also, selection of local faculties to pair up with the international expatriates in terms of matching them for capacity building has been a big challenge. Sometimes the local faculty that we attach to the expatriate, they don't match really very well, and therefore transfer of skills and capacity building from the international expatriate to the local faculty does not happen that very well. The other challenges we have is with difficult outreaches and community engagement activities. You know, here we have uncomfortable means of transport, including motorcycles. So, and then the road conditions may not be very good. So this has been a big challenge to our international exchange expatriates. Of course, cultural shock. We have programs where we conduct home visits. Sometimes the gender norms in the homes can be a shock to the international expatriates. Of course, language barrier during outreaches and community engagement activity is a challenge. What are some of the suggestions for maximizing contributions from international exchange? I think one of the key things I'm suggesting is considering the request from the host institution. The host institution should have that opportunity to request the international expatriate that they want in terms of qualification, in terms of experience, so that when they come, they fill in the gaps within the system. For example, currently we are launching masters in midwifery, so we would be interested in getting an international expatriate with a PhD and doctorate in midwifery to teach the master level students. Of course, effective pairing of local staff with the international expatriate is an area where we need to work on. I mean, we could pair in terms of interest, but also in terms of qualification and so on. And I think we're also suggesting that the local staff from the host institution should be given the opportunity to make a return visit to the international sites, because we could be practicing this thing here, but if we are given opportunity also to travel to the US, to the Europe, to go and also have the feel of how these equipments work there, it would be very supportive. And then there's need to incorporate scholarship for advanced studies for host institution staff in international exchange programs. I mean, there are many staffs in host institution that needs to go for master's degree or PhD degrees, but the scholarships are not usually part of the international exchange. And then I think there's also need to incorporate quality improvement projects into the exchange, especially in the clinical setting. If an international expatriate has specific skills, maybe to perform certain maneuvers, they should be given that opportunity to also improve the existing facilities, to build the capacity there such that they are able to perform those skills in the nearest health facility. And then we need to incorporate cultural festivities and site visits into exchange. Sometimes it really gets boring for the international exchange. Over the weekend, they are alone, they have nowhere to go, and they have no friends, they have no relatives around to visit them. So if there are cultural festivities and site visits incorporated into exchange, it can make the exchange interesting to the international colleagues. And then the host institutions should support with local ground transportation and housing. This is usually a big challenge, but I think administrators and stakeholders who are program leaders and university leaders in attendance, this is something we can lobby for, so that when we get international expatriates, we give them that support. And then we need to set up international office to support transportation, local movement, finding of housing, and many other things that international expatriates will need. Afoyo Makwe, questions, comments, and supplements are most welcome. Thank you so much.
Thank you, Professor. That's a very just on time. Thank you for your presentation. And I hope that some people have already started. Somebody asked whether you are a midwife. And could you? Yes.
Yes,
are you a midwife?
Yes, what I want to say is that my background training, bachelor's degree in nursing, has a component of midwifery. As I mentioned earlier, in Uganda, the Bachelor of Science in Nursing has the nursing courses and also has midwifery. And then my doctoral training is in reproductive health. So I am contributing to the midwifery trainings. Thank you.
Thank you so much. Thank you, Professor. That's a brilliant presentation and an insight of what is happening in that part of your country. Now, if we can move on, I would like Dr. Elizabeth to come on board. Please hold on, some questions are there, we will answer them, but let's hear from Dr. Elizabeth. Thank you.
Thank you very much, Madam Moderator. Let me say that I have issues with the connectivity. I keep on coming out of the meeting, and I've tried to join using my phone network at the moment. Let's pray that I get maintained in the meeting throughout. But otherwise, I wish to thank Afri Health for this opportunity that we can share common issues that we are experiencing as the midwifery training institutions. I know the title for my presentation is The Power of Mentorship Lessons from Midwifery Training in Malawi, but I remember having discussed with Dr. Bonaventure, and we had changed a little bit to clinical teaching and mentorship. So before I go into my presentation, as you have rightly heard, my name is Dr. Elizabeth Chodzaza. I work with Kamuzu University of Health Sciences. I'm an acting executive dean in the School of Maternal, Neonatal, and Reproductive Health. And indeed, it's a new school, and we are setting up ourselves. Of course, previously we were a faculty of midwifery. We've just transitioned into this new university. So as I have already indicated that this afternoon or morning or evening to others, I will be sharing with you issues related to clinical teaching and our experiences here. As we are all aware, midwifery education is a practice discipline where students learn the subject matter by doing the things that they learn in class, and they do practice the skills. So it is important indeed that after students have learned in class, they should be able to practice for different purposes. For example, we need to develop the technical competencies for our midwifery students. And indeed, we want them to practice on the various procedures that they have learned. And in the process, we maintain the high standard of midwifery practice so that they become independent in order to practice midwifery afterwards, after we have developed their cognitive, affective, and even their psychomotor skills. So it is an important area that we develop the clinical competences of our students. And the clinical teaching itself provides the space where our students or where clients are cared for and our students are able to practice. So in our setting, there are several attachments that our students go to, and they do apply the knowledge that they have gained in class, and even from the laboratory sessions that we do conduct with them to develop the competences for the midwifery practice. So attaining these competences actually requires our students to go through several stages. For example, initially, as I have already said, they get didactic classroom theory, and then sometimes they do attend laboratory sessions in order for them to develop the practice skills. And later on, they observe human care through demonstrations by the clinical teachers. And then they are also able to do repeat demonstrations under the watch of their teachers. And then the students begin to offer the human care under supervision of the experienced midwives, their lecturers, and indeed mentors. And the students later on, they do develop confidence in offering midwifery care through this repeated and consistent practice, whilst they are being monitored, and they gradually leave to give their own care out there after they have been well equipped. So Kamuzu University of Health Sciences, as I've already said, has a school of midwifery. And as a university and as a school, we have responded to the critical shortage of midwives in the country by increasing the intake of students. And the increase indeed has tried to address the challenge of numbers. But eventually, it has also heavily compromised on the quality of teaching and learning. Consequently, the quality of our graduate midwives. So the quality of midwifery clinical teaching and learning is heavily compromised because of increasing competences to be acquired by the students, scarcity of competences in the clinical sites, and also we have a challenge with inadequate role models in the clinical sites who can model our students the actual midwifery care. We also have significant gaps in the competence of our teachers, sometimes even the midwives on the ground who can actually model the students, because some staff in the clinical area sometimes do not have that adequate capacity to teach our students, and they are often also faced with some competing priorities, which leaves our students with few, if any, staff available to teach them. And sometimes the teaching schedules are disturbed because staff have other issues to attend to. So it is clear that there is an urgent need to address what has to be, what I've just mentioned as bottlenecks in the effort to provide or to improve maternal care. Generally speaking, we do provide good clinical practice with the challenges I have mentioned, but we are striving because we do have a well-planned teaching program which really provides a valuable contribution to the students. We set up educational objectives that the students are supposed to attain when they are in the clinical sites, which are also shared with the members in the clinical sites, so that everybody working with the students are aware of what our students are expected to attain, and that they are also supported on the same. And these educational objectives are derived from our midwifery curriculum. So you find that it is well organized. And before we send our students for clinical learning, we do scout for appropriate sites where clients receive good midwifery care, and also that provides the chance for the students to practice high standards of midwifery care, where we feel at least the numbers of human and material resources are something that our students can work with and be able to attain the skills that we wish them to attain. So our clinical teaching basically is delivered by faculty members from the school, and we also have well-trained preceptors whom we work with, as well as the midwives on the ground. They also work with us in delivering the teaching to our students. So us as the teachers, ideally, we set the objectives, as I've already mentioned. We set the standards for practice, that is apart from the regulatory body. And also we prepare master rotations for our students. And we set up the clinical area as an ideal manner where the students can attend the practice, of course, with some challenges. And we do assist our students to gain the skills that they are supposed to gain by role modeling. And we also try to encourage, motivate, and as well as inspire our students. And we develop some evaluation tools so that we are able to assess if at all our students are attaining the skills that we want them to attain. And we use various clinical teaching methodologies when we are working with our students in the clinical side, so conferences where we discuss issues pertaining to our clients, and we do the demonstration and the demonstration, and sometimes even clinical assignments as part of the learning processes. And we also utilize the midwifery management process. I know most of us possibly, we are very familiar with the wedding nursing management process. So it is the same process which we also utilize when we are teaching our students. And the key factors in the process is the problem solving, helping our students have organized thoughts as they are caring for the clients, and also have logical sequence in the delivery of care, and also some expected behavior. I'm sure we are most of us are aware of this process. But apart from saying whatever I have said, we have some challenges. Some I might have already mentioned in the process. For example, we lack adequate clinical teachers as well as midwife to mentor our students. We have insufficient space for the teaching itself because of the increased numbers which I've already talked about. And most of the times we also do experience some inconsistencies in terms of what we are teaching the students and what they are actually experiencing in the clinical sites. because sometimes our midwives on the ground may not perform exactly step by step the way we are teaching our students in the classroom. And sometimes we have inadequate teaching resources. A major element of the title that I was supposed to deliver this afternoon is regarding mentorship. And I wish to acknowledge in this meeting that as a country or as a nursing university, we have not advanced so much in terms of the mentorship itself. Possibly some of the reasons could be the ones that I have already alluded to, but I still want to say something surrounding mentorship. As we all know that mentorship is a process through which an experienced person or a mentor, her or himself, guides another person, or where in this case it means an experienced midwife mentoring a student midwife in developing skills and knowledge for their professional development. This concept has been there for years. Actually, maybe possibly we have delayed ourselves to adopt it to the fullest so that our students benefit from this arrangement. So the main aim to do mentorship is actually to enhance the abilities of the mentee, building their capacity to produce the desired career outcomes. Given the chance and the opportunity, I'm sure this is the way to adopt in terms of training midwives. With the challenges we have at the moment, we have taken a bold step to see how best we can incorporate the mentorship in our training. So I just want to give a small scenario in terms of what we have done so far in terms of mentorship. As a country, as I've already said, we are not fully implementing mentorship in the training. It is mostly the clinical teaching by the various people that I have mentioned. However, something is being done on the ground. The Malawi Ministry of Health, through the Nest 360, which most of us might be aware of, is providing mentorship training to various cadres of people on neonatal care. And the aim is to improve clinical care being provided to the neonates, thereby improving neonatal outcomes for Malawi. And the biomedical engineers, who are some of the group that are being trained in this, their role is to ensure that they take care of the neonatal equipment for its optimal functioning. And when we train decentrally, these people, the mentors, they provide institutional mentorships to their colleagues at the facilities. And we also have national mentors who provide support at their institutions. And the facility mentors also provide mentorship to midwifery and medical students coming from different institutions into the particular facilities. We have GAIA, the Global AIDS Interfaith, which is providing mentorship to midwives in some primary health care facilities in the southern part of Malawi in order to improve midwifery care to mothers during labor and delivery. So you can see that at least there is something happening on the ground, but we need to do more as I speak. And the clinical teaching is one of our major area that we really want to do well, because we know that's the backbone of our student midwives to be able to practice when they go out there. You know, when we teach the theory, it is very abstract. But if you take through your students very well in clinical teaching, you are assured of attainment of the skills, and you send out there capable midwives who are able to care for our mothers and their newborns. And in the process, we are able to bring down the maternal mortality and morbidities, which are high at the moment. So we are in the process of restructuring our clinical learning in order to enhance learning for practice. I think I would rather stop there Thank you very much, Madam Moderator.
You are muted. You are muted, Sister Amber.
Okay, sorry. I want to thank you, Dr. Elizabeth, for the marathon, and that is full of experience. You know, it cannot be overemphasized that no matter what, midwifery is hands-on. And to have a proper skills of practice, we need preceptors and mentors to mentor them until they come into their leadership role. And so midwifery will be a continuous process in the community. So now we have to go now to the questions and answers session. If somebody has something to ask, please do so with your hands up, and then we'll look at the chats. Thank you very much, the three speakers. You have done well. Though we can go on and on, because midwifery is the backbone of a country. I always tell my midwives, and I say, the future of a nation or the community is in your hands. Because as you deal with the mother, you are dealing with the continuity of that family, the continuity of that community. Because when it goes wrong, the baby, whether one or two, it's going to affect the community and the nation as a whole, and as well as even the mother or the baby itself. Because if the mother is not there and the baby survives, that baby is going to grow up, we don't know how, but it takes the grace of God to see that baby to maturity and to make an impact, positive impact in the community. So I thank you, all of you, and now we'll go to questions and answers. Any question, please? Or should I start? Because I do have questions. Please make a show of your hand. Okay, yes, please. Judy, please unmute and ask a question.
Good afternoon. Thank you very much for this wonderful presentation. It's a long time, Amber. Look at you. You are remembering me now.
Yes.
It's great to be part of this, just this webinar, and really, I'm so impressed by what has been presented and what is happening in our schools of nursing and midwifery in Africa. I am now speaking here like an African. I'm not even identifying myself in a country per se, but looking at myself as a midwife, as a nurse in Africa, and the initiatives around education for nurses and midwives in Africa. So my question is, from what my knowledge and understanding and experience is, the challenge we are facing is that we need the midwives. It is clear. I think there is nobody who ever doubts that we need midwives. We need nurses in Africa. But where I am facing a challenge, and where I would like us to come together as a community and begin to discuss deeply these issues, are key issues reflecting things like absorption. I have worked and lived in Sierra Leone for about 3-4 years, and I am told there are midwives who don't have PINs, which is their code for being paid on the government payroll in that country. So you train this midwife with these wonderful skills like Professor Kumakech from Lira has demonstrated, and then they cannot be absorbed. They end up again working as volunteers. The issue of absorption in Africa is a big problem. What is happening? I hear from Professor Kumakech in Lira, Uganda, that his BSMs who have come out as BSMs are graduating and are being absorbed. So I wonder what are the thoughts around the issue of absorption for our midwives particularly. Then the next question, forgive me because these are things that are dear to me. So that's number one, absorption. Number two, I have been pushing for advanced practice nursing in Africa, which is what this webinar is all about. When I go to the Ministry of Health, I get disturbed, saddened, and in tears to be told that the minister and the Ministry of Health and the organs and machinery within the Ministry of Health is saying, why do we need nurses with advanced practice skills? And in some countries, they are rolling back and saying, let us train a nurse for 2 years, and they come out and start working and looking after our sick people. Komakech is saying his BSM program is 4 years. He even said they got pushback because that is too long to train. They want people quickly. So when you have the ministry and the leadership of many of our African countries advocating for reduced training, lower level skilled nurses, and we are sitting here today in this gathering to say we want advanced training for nurses, what is the answer for that disconnect? And last but not least question to all of you is, every initiative that I've had presented here from Uganda to Zambia to Malawi and the wonderful things that we are doing, are we as a community of nurses and midwives in Africa looking at harnessing our skills rather than developing silo programs? Because it's very disheartening to go to Sierra Leone and see them training midwives for 2 years. You go to Zambia, midwives are training for 3 years. You go to Kenya, it's 3.5 years. You come here to Rwanda, it's 1.5 years. And it's so disjointed, so confused. So even when I try to speak and I talk to like our physician counterparts, sometimes who even themselves, they say, but you nurses and midwives look so confused. Are you a midwife if you have 2 years of training, or if you have a master's in midwifery and even a PhD? I'll stop there. Thank you, colleagues.
Thank you, Madam Judith. I see Margaret Manners' hand is up. You can unmute. And please, we need 2 minutes each because so many people want to say something and you have only 15 minutes. So
Thank you very much, Madam Chair. Thank you very much, Madam Chair. I am Margaret Titi Mana. I'm sure I have familiar faces. I was the country midwifery advisor and later midwifery specialist at UNFPA. I am a graduate nurse midwife with masters in sexual health. So I'm very pleased to be here. Thank you very much, Judy, for bringing up some of these critical issues. I think in responding to your question, one of the things is our history. The history is what that is chasing us. And sorry, I am not here to hurt anybody. Is our preparation. As you likely said, diverse countries are having 2 years. Some are having 1 year. Some people are even opting for lesser. It is because we ourselves, the leaders in this profession, where we have placed ourselves and the status quo, we do not readily or willingly accept change because things are changing. And as you likely said, some of us, our preparation, we were together with medical students, pharmacists in one pool. We did all the basic sciences. So with that foundation, I think we should be allowed to do advanced practice. Then secondly, is our regulation and being accountable. The issues, there is a lot of litigation, but because we don't have our leaders, I think moving forward, we should try to really encourage nurses and midwives to go for legal mindedness, at least doing some amount of law, so we are able to really govern ourselves well. Then that will help us to prepare. When my colleague from Uganda was presenting, you know, I started calling my team, please, can you come and hear? Because here we are so much in a rush to like do abridged programs rather than looking at the content of what we are going to do. I really appreciate that content. I think that was the foundation I had. You know, when we have diverse content in module or in curriculum, you will see somebody. I have had a doctor say once to me, what is it about to train a midwife? You can take anybody somewhere and give a 6 weeks training. You have a midwife. So if that is the type of people we interface with, and our senior colleagues, with all respect to them, our pioneers, they have been mingling with such people. That's why we have brought in this tax shifting or tax sharing, and it has killed our profession. So I think now AfriHealth is really trying to bring about emancipation. Who are we? So when we start defining ourselves, then we are able to stand autonomously for ourselves and take responsibility. Then I think we will be liberated. So thank you very much, Judy. So, and the other thing, I'm very happy I have my Deputy Chief Nursing Officer. She's on this panel. I hope we have some other more Sierra Leoneans who are here. So we start looking inwards to see how we are able to really match up based on international standards, not just do something, then at the end of the day, you are giving papers that you cannot justify or defend. So thank you very much. I am out.
Thank you, Margaret. I think Rebecca, no, Florence, but Rebecca's hand was up, who said Margaret has answered, asked a question. So now we say Florence, Matei.
Sorry, Madam Chair. I just want colleagues to see me. This is Margaret Manna from Sierra Leone. I'm happy to be on board. My camera was off.
Okay. Right. So Florence, can you come on?
Thank you. I'm just putting on the camera, but I'm in a dark space, so you may not be able to see me. I'm Florence Mate, a former registrar, Uganda Nurses and Midwives Council. Currently, I'm working with the University of Liberia, teaching midwifery. Now, my very brief. I would like to thank all the professors. I'm happy for Edward. You know, Edward was one of our people whom we groomed, and I'm so happy that he's here sharing the good work with us today. Thank you, Edward. Thank you, all the presenters. I have one comment or one recommendation to make. And that recommendation is that here in Liberia, I have found something which is very good. All the people, nurses and midwives, when they graduate at whatever level, they are registered as registered nurse or registered midwife. So it's when they get employment, it's when their salary schedules, salary scales change. Somebody is therefore paid as associate nurse, associate midwife, diploma nurse, diploma midwife, or a nurse with a degree. And this is one thing which we should be able to be looking at if we are going to look for employment. This happened in Uganda when I was still there. We were looking for all these people, but the issue is we were fronting our qualification. We were putting our qualification. We are nurses with degrees. We need such employment. And we were told, this is one thing I was lobbying for. And in one of those fora, I was told that we don't need nurses with degrees. What do they have to offer, which these other nurses can offer? So it became difficult. So my recommendation here as I end is that, colleagues, I think it's high time we looked at specialization, the very way that doctors do. In my country, Uganda, you find we have got doctors who retire at 60 years of age, but public service still takes them on as consultants because they are either pediatricians, they have done some specialization. With us, we are just holding these degrees and everything just like that. We need high time we started specialization so that our ministries, which employ us, are able to take us on under those specializations and under that salary scale. Otherwise, as of now, when we graduate, our salary is like a graduate, a university graduate. We need to start as this specialization so that we can be able to lobby for better remuneration. Thank you so much. I'm glad to have joined this forum. Thank you.
Thank you, Madam Elizabeth. Any more hands up? Awol, do you want to say something? Ariga. Ariga. Okay. Grace Danda.
Thank you so much for the wonderful presentations. We really learned a lot. I'm from Zimbabwe, National University of Science and Technology, Department of Nursing and Midwifery Sciences. And we have really learned quite a lot. I just have a few comments. Some of them may seem like a repetition, but I felt I needed to point it out. Like the issue of standardization. I think for us to really stand as a strong force, we need to be standard and we need to be uniform to say our BSc in Africa. If it's going to be 3 years, it's 3 years all round, not like different years and so on. I thought maybe since we are all supposed to be guided by ICM, we should actually get a lot of advice from them so that we standardize. And I had a comment to Uganda where they were talking about the 4-year BSc midwifery, which they seem like they combine both high school candidates and post-basic diploma students as mature entry. I'm not sure how proper that could be. I don't know, maybe it's me who didn't understand the mixture of someone straight from a high school and someone who is already a nurse who has had some basic training. I'm not very sure, maybe I might need a bit of elaboration, but generally I really feel people, our colleagues are doing very well and we will really take quite a lot from them. Thank you so much.
Thank you so much, Madam Grace. Elizabeth, I think you've spoken not so.
No, I have not.
Oh, okay, the floor is yours.
Thank you very much. Actually, I wanted to respond about the specialization in midwifery. I thought I should give a scenario from Malawi. As I already said, from the University of Health Sciences, Kamuzu University of Health Sciences, we have a ladder in midwifery training. For example, we have a Bachelor of Science in Midwifery, and this is a direct entry program. We also have a Master of Science in Midwifery, and we also have a PhD in Midwifery. So indeed, all of us maybe can adopt a similar way of a ladder. So in this case, we would say there is a chance for specialization in terms of midwifery from our country. So we can claim that we have got advanced midwives based on the trainings that our students are going through. Thank you.
Madam Elizabeth, I think we are almost at our end. So I will have my own questions and our presenters will say something to round up. Now, talking about the gaps, Madam Sarah, in the pipeline of nursing. How do you do your trainings or your postings? Do you have straight direct entries? You know, because when you have direct entries, you start molding them and they move on to PhD or, you know, as far as the individual would like to go. And yes, how is posting done? You know, how is your not curriculum, your scheme of service, because that also can have an effect in having your CNOs or CMOs, chief midwifery officers and chief nursing officers. How the way your
trainings.
Yes, you know, the way promotion is done, you know, make space for the younger ones to come on board and all that. Then now, yes, please.
You have another question?
Yeah, well, not for you now, for Professor Edward. Professor Edward, how do you train teachers specifically? Because midwifery is a specialty. And so teachers must, the tutorial team must stand out. In Sierra Leone, I'll have to give a Sierra Leone scenario at the end of the day. But teachers must stand out for midwifery so that you have enough of the type of teachers to teach the different levels of midwives. And Dr. Elizabeth, yes, mentorship and preceptorship. That also there are outlines or guidelines how to train them. If they are available in the hospitals, then I believe you'll be able to master that area to mentor or precept whilst they are still in training, the midwives or nurses as the case may be. I will wait for your reply and then I will give Sierra Leone scenario. Thank you.
Sarah? Thank you very much. Yes, so in Zambia, we have different levels of training. So we have the advanced diploma in midwifery. We also have the diploma in registered nursing and midwifery. We also have the BSc midwifery, and we have the masters in midwifery, and now we also have a PhD in midwifery. So the masters and the BSc and the PhD just started recently. We didn't have those courses. So we just, I think for the masters, we'll be having the first graduates. And even for the, we only had one graduation rather. And for the BSc midwifery, we are going to have the first graduates, I think next year. And the PhD just started. So in terms of how leadership have been appointed, like I said, so our director nursing services, who is not a midwife, is a PhD holder in nursing. So she was put in that position, I think, looking at the qualifications. But we have one PhD in midwifery. By the time that that other person was being appointed, she was in the university and was a lecturer there. And in fact, before that, she was outside the country. That's why she was working. So maybe that gap was quickly filled because there was no one to fill that gap. But not even that. I think even the way the appointments are made, kind of, you know, our African leadership is weird, for lack of a better word. So you find that even as you are doing the, like I said, we don't even have that deliberate policy to have succession plans. So what it means is that anyone that is available at a time, that is maybe the leaders who are in position, political leaders have seen that they will need to maybe to appoint this one. They just appoint without looking at what somebody has. Yes.
Okay. Thank you very much. We barely have about 10 more minutes. We need to be rounding up. Professor Edward, do you have anything to say?
Yes.
Madam Chair, please, yes. Can I ask Professor Edward for one clarity?
Okay, go ahead. Because
yes, when he was presenting, he mentioned they have a director of nursing, then they have a chief nursing officer for ASRH and some other programs. I really want some more detail. I don't know his email address or contact, or probably he can just give us some insight. Then in his presentation, I heard the director of nursing was not a nurse. So how is that? Yes. So I just needed, I don't know whether I heard him say the director of nursing is not a nurse or so. Then how are those CNOs being posted and what? Yes. Thank you.
All right. I think this session, Mr. Ibrahim, I'm giving you just 1 minute. I must round out.
Okay. Yeah. Thank you so much for the chance to answer some of the questions. I see there are a lot of questions in the chat, but I will answer
Thank you.
The key one.
Thank you very much.
About the entry program. In Uganda, we have different midwifery training programs. We have a certificate in midwifery for 16 to 17-year-old young boys and girls who have just finished lower secondary school. So they would join and get certificate in midwifery, 2.5-year training program. But we also have diploma in midwifery training program for young boys and girls of 18 to 19-year-old who go for diploma program. And this diploma training, excuse me. So we have diploma training program. In addition to that, we have nursing programs with midwifery contents. So you may find somebody is getting diploma in comprehensive nursing. It is both nursing and midwifery. And then we used to have even what we call double train. Somebody gets a certificate in midwifery and then also a certificate in nursing. Or somebody has a diploma in nursing and then it adds up, comes from an extension program for 9 to 18 months to get midwifery. So we have all these categories of nurses and midwives. So at the university level, where we are training degree, we have entry criteria where we sometimes admit diploma nurses and midwives. And we could also admit students directly from high school. But we train them the same training program from scratch for 4 years because they have to redo everything afresh because of the differences they have in their background. So that is how the training runs. And then thank you so much.
Yes, sir. Well, I don't, all countries has diversities. Mr. Ibrahim, please, 1 minute. I must round up. You are not ready. Okay, now let me do my rounding up. Thank you, all of you, for being, all right, Mr. Ibrahim, please say quickly. Your question, please, or your comments, please, Mr. Ibrahim. Time is of the essence.
Hello. Okay, thank you. Just to say shortly, I think I could suggest we need to have something like a job description, a framework which is maybe harmonized with the different countries, that we need to have a consultation between the one cadre, maybe from the certificate to diploma to a certain scope, which has boundaries of activity to be done from one level of education to another. We will still continue to suffer the same problem that other countries say that we don't need a nurse with a specialty. For what? We don't need a nurse for PhD. For which purpose? So as bodies or as experts in nursing, we need now to come up with a certain framework of maybe job description or a certain scope of practice, which will be harmonized in maybe a certain region, or if it is sub-Saharan Africa or whatever. I think it will help in somehow. And also maybe ICM, ICN those who are dealing with nurses and the midwife can help on this. Thank you very much.
Yeah, thank you very much too. Now, my rounding up. I want to thank everybody for your participation. It has been active and proactive. This time is really not enough. Nevertheless, I want to say that absorption of taking employment is money. And so even though midwives or nurses are working temporarily, the provision is being made for them for their absorption into the civil service. We are not only training for the civil service, we are training for the private also. So that's where the synergy comes in, private and public synergy. So this we must consider and employ people accordingly. The intake of nurses and midwives. For us in Sierra Leone, we have separate schools for midwifery and separate schools for nursing. So we do not mix them. If you want to be a midwife, at first, every nurse is a midwife. I'm a nurse. That's where I started and moved on to midwifery because that was the opening that we had. But I'm sure all of us are having different types of openings now. As somebody spoke about specialty, it is a key word. We encourage, us in Sierra Leone, we encourage nurses or applicants to go for specialty. We are at the conclusion of midwifery direct intake in Sierra Leone. Come next year, we are going to start direct intake. As it is now, it is a postgraduate course. But mind you, as you go in it, we don't want a switch over from it. Everybody must find its place, whether it's a pediatric or mental health or midwifery or special care nursing, whatever it is, you must take your road and move up the ladder. So as you take your road, you are being groomed. After every training, there is a 1-year internship wherein you are monitored for practicing your skills so that you will be competent in whatever in your field, and then you move on. So we are moving on in Sierra Leone, and I hope every nation in Africa will move on. I saw a comment that it is very unfair. Really, it is unfair to have postgraduates and direct intake together in the classroom. So, notwithstanding all, I want to say again, thank you to AfriHealth for this podium that it has created. I hope we'll meet again. Thank you, all of you. Thank you, Sarah. Thank you, Edward. And thank you, Elizabeth. Thank you, all those who have their comments and have written it. Thank you very, very much. Thank you. We are leaving now, and I'm signing out. Thank you very much.
Thank you very much.
Thank you, Sister
Thank you, everyone. Have a good
Bye, thanks.
Bye.
Hashtag blessed.
Thank you. Bye.
Thank you.
Bye.